We now move on to the next, or rather the first session, the first substantive session. And this session is part of closing the care gap conversation that we have started. Can you hear? It's better now, yeah? Okay, sorry about that. So it's part of that conversation we're having today about closing the care gap. And I'm really very pleased to have with me, apart from the fact that they are very strong women sitting around the table with me, they're also quite eminent experts in their respective areas. And I think they have been introduced, Dr. Noraryana, Dato Saunthari, Datin Paduka, Professor Teo. They are friends, so I may end up calling them by their first name, so please excuse me if I do that. The idea of this team is that we are trying to galvanize all stakeholders to come to a point where we think about closing this gap. And this is in fact the third year we are having this conversation about closing the gap. And what this session hopes to provide you is a sense of where we are in some of the areas. So Noraryana has got, is going to talk to us about what the Ministry of Health is doing. Sounthari is going to talk about what civil society, NCSM is doing, and Soo is going to talk about the cancer research in Malaysia and the work that they do in cancer research. So the way I was proposing for us to proceed is I'm going to pose questions to them and they will answer the question. I'm trying to keep this interactive. Usually when one speaker is speaking all the time, the others sleep. This time I'm going to keep jumping from one to another so they're all awake. And then at the end, I hope you will get time for one or two questions from you, because I've been told that I have to finish by 12:30 so that we all can have lunch or maybe the next session can start. So let me start with Noraryana. The first question I have is cancer care in the post-COVID era. What kind of successful solutions have you been able to implement?
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Very good afternoon. First of all, I would like to thank the organizing committee for inviting me today as a panelist in this closing the care gap, the role of Ministry of Health. I think questions from Prof. Elil is now what is the role of Ministry of Health and what is the what we have been doing in the post-era COVID in terms of cancer care. For your information, the role of Ministry is very important because we do planning, we do implementations, and definitely the planning and implementation were based on some strategic planning. So the first blueprint that we had was 2016 to 2020, and the latest National Strategic Plan for Cancer Control we had it in 2021 and 2025. Actually, we are really focusing in terms of the care of cancer from primary care, secondary care prevention, tertiary, and in fact to the palliative care. So we have focusing in 10 focus areas. We do a lot of prevention and health promotion. Of course, screening and early diagnosis is one of our main factors that we are actually focusing for cancer. We also focusing on diagnosis and of course on the treatment. And definitely when patients have been diagnosed to get cancer, we also focus in this National Strategic Plan on the survivorship, palliative care, and definitely one more thing to make sure the patient to get some like palliative care and some sort of to relieve whatever pain that they have. We also focus on the traditional and complementary medicines. So besides that, Prof. we also look into a lot of research and development. This is also one of the areas of Ministry of Health is focusing right now. We are looking forward to work together with all of you here today. So probably in the discussion in the afternoon, we can also explore more research and development that we can do. And the other thing is on the monitoring and surveillance. So this is another important issue, because in the national strategic plan, we focus on cancer registry. So we really want to look into what is the main issues of cancer in Malaysia by doing this monitoring and surveillance. And the last thing that we really focus on is on the human capacity building and development. You know, lessons evolve quickly. There's a lot of new way of treatments and so on. So one of the focusing areas is to make sure our paramedics, our doctors, our specialists be updated to the latest updated versions of the way of how we can treat patients. So this is actually the holistic approach of what we are doing in terms of the cancer program in the Ministry of Health.
Thank you very much, Elil. Civil society organizations play an important role in terms of closing the gap. What kind of challenges do patients face in Malaysia?
Thanks, Elil. That's a question which will keep us here the whole day. But I'd like to just divide it into 4 main areas. The first is access. The second is equity. The third is financial. And the fourth is psychosocial support. So when we talk about access, despite all the programs which are out there, there is still difficulty in access. And there's a huge gap in terms of urban and rural access. The time it takes for someone who's in the urban area to be able to get to health facilities compared to those in the urban area, there's a huge gap. And then when you're talking about equity, with that geographical disparity, is that the type of services that you have in different areas is vastly different. What you get in a rural area compared to what you get in an urban area. So, I mean, those are just some examples. Time factor makes a huge difference for a lot of patients. So traveling makes a difference, the waiting time that you have makes a difference. For patients who are daily earners, they can't take the time off because it means then they're not going to make it. They're not going to have to get wage. So all these factors, which people think are not major factors, people focus in terms of the treatment aspects of it, but they don't think about the logistics in accessing treatment. Those are gaps that we have to cover as well. I think delays in terms of diagnosis. So once a patient presents themselves, even with breast cancer, an area where we think we have the most services available, studies have shown, I mean, Aisha's study in terms of the breast cancer care timeline, shows that you can have delays, I mean, you can be seen in a day. You can get your investigations done within 4 days, and treatment initiation can happen within a week. However, for most people, the delays can be 2 months, 6 months, up to a year before initiation of treatment. And even if you've done your investigations, the recall or being even told what your investigation report is can take a delay up to 6 months. So making sure that we can cover those gaps, that even if you've done the investigations, that you get your results in a timely manner, and then you get referred in a timely manner so that your treatment staff is an issue. I think the other issue, which is a huge issue in terms of your timely access to care, is that every single service is in a different hospital. So you might get your investigations done in one hospital, and then you have to go and see a consultant in a different hospital. And once your treatment plan is given, you might have to go to a different hospital for your chemotherapy, or a different hospital for your radiotherapy. 25% of the population is 100 kilometers away from a radiotherapy center. So all that, with all those challenges, you're not going to get compliance in terms of treatment. So these are, I'm just talking about access and equity. Equity, of course, is the difference between public and private healthcare. And then if you go down the road of financial and psychosocial as well as challenges that we have.
Thank you very much. I think it's really good to hear that from a patient perspective. So, research gaps. It's an important area. So, what kind of research gaps are there in Malaysia?
Thank you, Elil. Well, first off, thank you to NCSM for including a space for research, because oftentimes when we're at events like that, people think research, what's the point of thinking about research, right? So let's go back to statistics and think about why we're talking about research. So 100 years ago, only 1 in 10 individuals would get cancer, and nearly all of them would die of the disease. So just reflect on that, right? 100 years ago, everyone who got cancer would die of the disease. But where are we today? Because of research, we're able to cure more cancers. So if you look at a country like the US, for example, you heard the statistic this morning that 1 in 2 individuals may have cancer in their lifetime in Europe and in North America. But the reality is that overall, most of those are going to survive the disease. So 60 or 70% of those individuals are going to survive the disease. So overall, if you look at the population, you might say maybe 1 in 8 individuals will die of the disease. If you look at Asia, on the other hand, today, 1 in 3 of us are going to get cancer. But the worrying thing is that survival from cancers in Asia is lower than that elsewhere. So there are 2 research gaps. Number 1, why is it that some of the cancers that are more common in Asians happen in Asians in the first place? And what must we do to cure those cancers more effectively? They include some types of lung cancer, oral cancer, liver cancer, stomach cancer, all of the things that are more lethal. So that's definitely one research gap. The second research gap is really about, well, we have all of these treatments that are available, but they're not affordable. They're not for you and I. So how do we make them more affordable? And I think that's where the second aspect of research comes in. How do we make treatments that are available, screening that is available, that is doable? How do we make it faster, cheaper, and better? So in my team, that's actually what we're doing. I tell my team, this is what we're trying to do as researchers. Make things faster, cheaper, better. Otherwise, there's no point. Right? We're here to make sure that we can fill the gaps.
And in terms of the types of cancer research, which is critical to, you've already mentioned something about affordability. What else is needed?
So there are 3 types of research. We certainly need discovery research for some types of cancers that are just more common in Asia, and no one has done that type of research. So because the patients are here, they're not in North America, where most of the money for research is, we just simply need to invest in that type of research. But the second type of research is also about things that are unique to our population. So for us, eating soy, tempeh, and so on are very normal. They're part of our everyday diets, and they're not normal part of other people's diets. So we need to understand how are the lifestyle factors, how are the dietary factors, how are the behavioral factors in our population impacting on cancers, and what are the positives out of that we can learn that can change things that are acceptable to our population. But finally, the thing that is really, really important is healthcare itself. How is our healthcare built? Because healthcare systems in the US is different from the healthcare systems in Europe and different from Malaysia. So Son has already mentioned the challenges that patients face here. They're unique to the healthcare systems here. So we need to be able to find those and come forward. So if there's one message that I would like to leave with everyone in terms of research, is that research isn't just about finding a cure. Finding a cure is absolutely critical, but now we need to do research to try and figure out what type of screening should we offer. Should we offer screening to individuals who are very high risk, or should we make sure that everyone attends at least one screen in their lifetime? Which one is faster, better, cheaper? What should we do first? We should apply research methods to make sure that when you have less money, you use that money and that resource as effectively as possible to bring equity and access to as many people in the population as we can reach.
Thanks a lot. Thanks a lot. Noraryana, the Ministry of Health, what kind of future solutions are you planning? How is that looking in terms of the milestone?
I just want to inform you that totally we are in a new group of people in the Ministry of Health. we are under the disease control divisions, under the non-communicable disease. So we have a new team. So in this 2024, I have already discussed with the team to move forward in terms of cancer, and our what we were planning is on to focus, especially number one, on the screening. So definitely, I agree with Prof. here just now that we have to look into what type of screening that we should be focusing on, and who is the target person that we should be looking for on the screening. But at the moment, in the Ministry of Health, we are focusing in terms of three main screening, which is the colorectal, IFOP test, of course the mammogram and the breast self-examinations. We are going to continue to enhance and strengthen the screening, and on the pap smear and HPV vaccination. So we really want to work closely together with the NGOs, with any organizations who really want to close the gaps, because it is also very difficult for us to achieve the target of screening that we want. The other thing that we are looking forward is to look into other screening modalities like other cancers, probably lung cancers and so on. But I'm looking forward to work also with you, Prof, so that we can discuss on other facilities in terms of other cancers like lung cancers and so on. So the other number two on our focusing right now is, besides screening, we need to confirmatory tests. So this is another area that we are having quite a big gap. As for example, in terms of the colorectal cancer, when we test for IFOP, there's quite a long gap to confirm in terms of the colonoscopy. So I'm looking forward. I can see a lot of agencies here, Coral, for example. I can see a lot of private hospital. So we would looking forward to have public-private partnership. I've already talked to my officers that we are going to do this for this year, and starting from this year onwards. And definitely in terms of the improved access to the care treatment. So this is already been planned in the National Strategic Plan, where currently our oncologists in the country, 5 oncologists to 1 million population. So planning to increase to 10 oncologists to 1 million population. Definitely we are going to discuss with the Minister of Higher Level in terms of increasing the training and so on. And just now we had a discussion with the media. We also talked about the cancer treatment facilities. At the moment, all these cancer treatment facilities is actually concentrated in the Klang Valley. Not much, especially in the Pantai Timur, East Coast, where Kelantan, Terengganu, I think the access to the treatment is also difficult, as we mentioned by Dato just now. So, in order to do that, we are working together with the state hospital, especially USN and so on. So these are the 3 main areas that we are looking forward, especially for public health. As I mentioned, we are looking into the screening and focusing on the confirmatory tests.
I think really, it's really nice to see, but I'd like to add to what you've already said, which is we must recognize that improving treatment outcomes for cancer patients isn't just about oncology. It's also about surgery. It's also about radiotherapy. And actually, if we think about services, we must make sure that we include good evaluation of surgical outcomes in different parts of the country, because access to surgery is actually going to cure more breast cancers than access to oncology, if we can get it to the right patient at the right time. Access to radiotherapy is going to cure a lot of nasopharyngeal cancer patients. So, the efforts to set up new cancer centers is really important, because it's not just about focusing on oncology and delivering chemotherapy and targeted therapies. I understand there's a benefit there, but we must take a more holistic view of all of the services that are required.
Thanks, Ariana, and thanks also, Sue, to add on to that. In terms of the work that National Cancer Society is doing, what is your contribution?
I'm following up on what Sue said, having the surgical and having all the services there. The other part of that whole thing, are getting the patients there at an earlier stage. Getting them to be able to go to those centers. and presenting at much earlier stage. So a lot of the work that National Cancer Society does is in that sector, is in that health literacy, health promotion, in talking to people to destigmatize that whole area of cancer, so that people are more willing to go for their screenings, to go for their tests. I mean, Noraryana talked about doing colorectal screening tests, but even with the colorectal screening tests, those who came back positive, I think we have over 20% who refuse to go further in terms of getting their investigations done or getting their treatment done. So it's really, really important to be able to reach those people and talk to those people and have that time to actually change their behavior and change their outlook in terms of what cancer is. So in the last few years, the National Cancer Society has realized that it's no longer waiting for people to come to you, it is actually going out into the community and doing the work there. So when I talked about access, people not having the time to go to screening services, etc., we bring screening services to them. So it's ensuring that people can get screening services or can get health services outside of the normal working hours, whether it's after hours, whether it's on the weekends, etc., making sure that we're making it more accessible to them. And so there's no real excuse in that sense that I can't do it. So that's important. The other aspect of important is really providing investigations in economical, as Sue said, faster, better, etc. So to get that timely diagnosis, what the National Cancer Society has done is that we're working with private partners, we're working with private hospitals who have overcapacity in a lot of their investigations, to actually send patients to them to get the investigations done. And yes, these patients then get put into the public health care sector, but at least they've got the investigations done, and it cuts down that diagnosis interval, which is currently the backlog which you have in a lot of government hospitals. So it's providing those sort of investigations to patients either subsidized or charged through our centers or private healthcare.
Thank you, Zoe. Very impressive. So, specifically, cancer research Malaysia, what are you doing?
Sounds like a test, Elil. You put me on the spot all the time. Luckily, we're good friends and I can forgive you very easily. So Cancer Research Malaysia does three things. The first is we're trying to make new treatments available for cancer patients. We have a cancer vaccine that we hope to take into phase 1 clinical trials. Super proud of that, because in animal models it's got a 90% control rate of our cancer. Number two, we've been trying to bring in new investigator-initiated trials, testing specific things that work in the Asian population. So we identify a genetic variant as associated with patients that may be more likely to respond to immunotherapy. We've just completed that trial and was presented in ESMO last month, and it shows that there is a better response for immunotherapy in Asian patients. And that work was all led by Asians, led right here in Malaysia, and taken all the way from laboratory all the way to the clinic. Super proud of the whole team that was able to take that forward. But I think in the treatment area, we're starting to recognize that there are other opportunities of benefiting patients now. And one of the areas that we're investing in is trying to figure out whether a lower dose of checkpoint immunotherapy or immunotherapy will benefit cancer patients. So immunotherapy is already transforming the care of lung cancer patients, melanoma, breast, and many other cancers, but at 300 to 600,000 ringgit per patient, it's largely unaffordable. So we now have data to suggest that a lower dose will work, and we're working very closely with Dato support to try and bring forward a low-dose trial, so that if this really does work, we might be able to think about how selected patients may benefit from a lower, more affordable dose of this drug. These are the types of studies that, as a charity, we want to invest in more, because it's about closing that gap between high-income patients who can't afford therapy today and low-income patients who are told, I'm sorry, you either sell your house or you don't really have any treatment options now. That's one area. The second area of research is in screening and prevention. Super proud of the team. They are in Sarawak as we speak, with a mobile phone app that is AI-enabled, that you can take an image of a person's mouth in a rural location, upload it onto the cloud, where an AI tool essentially tells them whether it's an ulcer, it's a pre-cancer, or there's something stuck from lunch in your teeth, and you can just gargle your mouth. But essentially, it helps a patient figure out whether they need to be referred to a clinician or not. So in partnership with the Ministry of Health and many others, we're looking to bring this out to the rural population to enable early detection of cancers. We've also done a lot of work with high-risk individuals. So we were able to set up the first risk management clinic with Prof. Aisha, who's in the room, as well as Prof. Wu and many others for BRCA carriers, working with clinicians across 23 hospitals who were able to make genetic counseling and testing for ovarian cancer patients available. We're now working on an Asian genetic risk calculator for breast cancer patients. It's now in 4 hospitals. We hope to make it more available in other hospitals. So we're taking stepwise in terms of really moving from all the way from tool development to the, my first job was to stand outside an OT and collect a bit of tissue from a surgeon who's just performed surgery. So to kind of go from that to set up the cell lines, to recruit patients, to do the clinical studies and actually take something into the clinic has been a fantastic journey and possible because of an incredible team as well as many donations from the public. But the third part of what we do is recognizing that there's a gap in survival between high-income patients and low-income patients. We need to serve the low-income patients. So super proud of the team that are here. So Jana, Mahes, Aisha and others and the team are here. We've been able to set up a patient navigation center, first in Klang, now in Seremban, Kuching and KK. Really would love to work in partnership with NCSM. We work in partnership with everybody. And to really set up how do we ensure timeliness of diagnosis, timeliness of treatment, as well as adherence to treatment. We've achieved all of the WHO targets in our 4 centers. We've just published a paper in ESCO's Journal of Global Oncology. Our aim is to get to double the number of centers by the end of this year, and then make navigation available for other cancers, and start to work with other agencies to how do we figure out navigation for the community. So apologies, I'm hogging the microphone a little bit. I shall let it go and hand back to you.
But I'm not going to let you go without asking you a question. Who funds you?
You're not here. I'm a professional beggar. I'm scientist number 2, beggar number 1. So that's the reality of my job. So Cancer Research Malaysia is fully funded by donations and by research grants. So my team worked really hard to win international grants. So we've been very privileged to win grants from the Wellcome Trust, the Medical Research Council, and recently from the National Institutes of Health and the Bassett Foundation. But ultimately, the science that we do is funded entirely by donations. So if the donations dry up, we don't really exist anymore.
So there was a reason why I asked that question. Because you have spoken quite impressively about the work you're doing. So I'm going to tell all these people out there to donate to you. Yeah? So please do that. Again, coming back, you had some solutions. Quite important solutions. Have you thought about the possible challenges that you may face? What kind of mitigation strategies you have to do?
I'm happy to listen to Prof. Wu mentioning about the cost actually in terms of the treatment, and then it's about comparing between the affordable and non-affordable patients. And I think the most challenging part for the cancer is the cost of treatment. So that is the very important issues that we really need to highlight. You can imagine in a B40 group, if they can't afford to get the treatment, then how we could help them. And based on my data here, we know that the cost for treatment is actually highest on the hospitalization. Because cancer patients need to be admitted, they need to go for chemotherapy and all that. So I experienced myself when my sister got cancer, so I need to bring her down to the hospitals and all that. So there's a lot of money to be used for the patients. And then again, the medications is also very expensive. Some of the medication is not available in the government hospital, because some of the medication you need to pay half and then you claim back as a government officer and all that. And then, of course, the complementary test, whatever test that we need to go on. So all this is, I think, the most challenging part. And how we close the gap, so we need to think, and we need to be together today on how we can improve these issues. And I'm glad to hear from the Minister's speech this morning, NCSM is going to have the Global Trust Fund. We're looking forward to work together with NCSM on how we can choose patients that really needs in terms of the issues of funding for the cost. So that is number one. Number two, the possible challenges that we are looking into the issues of very difficult to trace back patient, defaulters. Okay? At the moment, we don't have any system to monitor. Most of the time, we are still looking into our systematic recording and so forth, so on. So what we are doing right now, we try to develop a patient navigation system. So that is another thing, and I heard that many NGOs, many bodies, they also have their own patient navigation. So probably today, in the afternoon, we could discuss on how we can organize the patient navigation so that it can be shared, it can be used together so that we can close the gap in terms of to overcome the challenges. And the third challenges, and I think this is a bit simple, but it's also very important. Prof also mentioned about technologies helps people to keep and all that, but technologies also give challenges to us. This is all Google doctors, you know, they don't want to come to hospitals, they Google and they try to seek traditional treatment. So this is also very important issues and very challenging to the Ministry of Health. So we need to really focus on how we should tackle in terms of giving more education so that they go to the right person. If you seek, you go to the doctor, not to the Google doctor and so on. And the other challenges that we really looking into how we tackle this into the anti-vaccine group. So this is another issue that I think I saw Dr. Rafida here. Dr. Rafida is one of our media social really fighting on the anti-vaccine group. So this is another challenge that we really need to focus on how we can close the gap. And I really hope that this afternoon during the workshop we can come up with a new solutions on how we can overcome all this gap.
Let me please follow up again. Where do you see private-public partnership contributing to your solutions?
Public-private partnership is important in terms of treatment, confirmatory test, treatment, and so on. Because if we can work together with the private company, for example, we can work on how we can share the costs between employer and benefit. We did this for kids smoking program. We had an example for kids smoking program where we asked the company to sponsor amount of cost for the treatment of the kids smoking. So probably this modality can be used in terms of the treatment for the public-private partnership. So this is probably one area that we can explore.
Thank you. Sound fitting the solutions into the bigger picture.
I think I'm going to go back to together we can do better. Noraryana has spoken about what they want to do, what the roadmap is for the Ministry of Health. But together we can do better means that roadmap has to be visible. The strategic goals have to be visible and transparent to all the players around as well, so that we can look at where the gaps are and then where our expertise can actually fold in seamlessly into that strategic plan. And this is where I thought, there's a lot of duplication of what we do, whether it's, with Ministry of Health or with other NGOs. As Soo said, they do navigation, we do navigation, MOH is doing that navigation. So there's a lot of duplication there. So we need to change that duplication into integration. We really need to integrate our services, but to integrate our services, we need that data breakdown. We need to do the needs assessment of where we are required, what we can put into those areas, and so that it's a seamless journey for a patient from start to end. And I think one of the programs which is trying to do that is the City Cancer Challenge, where they're looking at the area, looking at the needs of patients in that area, from community all the way up to hospital, and utilizing all the players in addressing those gaps. So be it whether it's civil society organizations, whether it's Ministry of Health, whether it's academia, and private equity firms and financial institutions, etc. It's bringing everybody together to look at how do we actually give a more holistic approach towards cancer treatment. So, I go back to the other question.
Thank you. You've explained that you've given us a lot of information. What else?
I have one request of everyone here. So Elil, I'm going to put you on the spot. If I say red, yellow, green, what's the first thing that comes to mind?
Red, yellow, green. I will think of traffic lights.
Very good. If I say heart, what will you think of?
Love.
Absolutely. If I say cancer, what's the first word that comes to mind?
Cancer, death.
Absolutely. Cancer equals to death. So if I have one request to everyone in this room, and many of you are survivors, please don't go out there and tell people, 1 in 2 of you are going to get cancer, 1 in 3 of you are going to get cancer. Do you know everyone's going to die of cancer? Do you know how much it costs, etc., etc., etc.? Because, trust me, everyone is already scared of cancer, and everyone already thinks cancer equals to death. So we need you as survivors to help us change that view. Because the fact is that you are survivors. Many of my friends are survivors. And they come up to me and tell me, cancer changed my life. Cancer made me recognize that every day I wake up, I'm grateful for today. And I've learned so much from cancer patients because they've taught me to be grateful for everything that I have. And if we have more gratitude in our life, cancer should equal to hope. Cancer should equal to a better life, a second chance to do for gratitude and other things, right? So my one wish for the collaboration, that together we can do better, would be, let's talk cancer differently. Let's make sure that we talk cancer in a way that projects hope, projects that we can do better. And maybe that should be the one wish that we have as an association.
So you tricked me into the questions. The next time you ask me the question, I'll say hope.
You have to look, National Cancer Society, giving hope, celebrating life. There is no talk about death.
Sound, you know, a bit slow in these.
Well, educate me.
Okay, you can understand, these people have got no respect for me. I would like to really offer maybe 1 or 2 persons to make a comment, but I don't know how this works. There's a microphone in the middle? Okay. So if any of you wants to make a comment, we've had some very powerful women experts provide their thoughts, but if there's any specific, you want to say something? Please, give us your name and then.
A very good morning, distinguished doctors. Really appreciate all that has been said. My name is Dr. Brandon Gomez. I'm a psychologist, and I used to be involved in cancer research. And we have a very caring government now, and I commend all the efforts that is being done by the government and by all the NGOs. My concern is on psychological support for cancer patients and their families. What efforts are being done to increase psychological support for them? As well as, secondly, what efforts are being done to increase funding and grants for cancer research to find better treatments to give more hope for cancer patients? Thank you.
Can I answer the first one?
Yes, please.
Okay. In terms of first one, psychosocial support in Malaysia is actually growing enormously. The National Cancer Society has a psychosocial support centre. We have our hotline, which provides counselling, social services, psychologists, a dietitian as well, and we do financial and medical counselling as well for patients. So this is basically a hotline, so you can do it in person or you can also do it virtually. What we're trying to do is to bring it to every state as well. So it's just not in Kuala Lumpur, it's in Malacca now, and in Perak as well, in Ipoh, and we're going to be starting up in Penang as well to have in-person office there to provide all these services. But on top of that, when you talk about psychosocial support, it's also building the capacity. There are, I think there are 10 cancer psychologists in the country, clinical psychologists. So it's building that capacity. And that's what we're doing as well. On World Cancer Day itself, we announced that we're having courses for counsellors and psychologists to be more well-versed in terms of cancer. So it's building that capacity so that you have a greater number of people out there who can provide these services.
So probably I can answer the question number 2 in terms of the grant for cancer research and so on. For the Ministry of Health, we have this, what we call under the IKs, Kesihatan Umum, NIH, National Institute of Health. We have actually allocated certain amount of grant, but I can't recall how much is that, but it can be applied through that grant. And in terms of which area of research, NIH also has one booklet in terms of the gap of area of research, and I do remember inside that there's a lot of gaps area in terms of research for cancer. So probably that answers the questions from the gentleman just now.
Thank you, Renganathan. I think you all have heard quite a lot, very insightful comments from the panelists. I probably can't, give you a very good summary, but I'll try and give you some of the points that are coming up. I think there are challenges. We've heard about the challenges with detection, diagnostic delays, the insufficient and disparate access to treatment that's come up a number of times, and the unmet needs in social, psychological, and financial aspects of cancer. I think we sometimes forget how much of a financial hardship having cancer and the cure of cancer come out what that means. And my colleagues and friends have spoken to you about the opportunities. There are quite a lot of opportunities. I will remember hope. There's a lot of hope. And that could be in terms of screening, early detection, improving treatment and care, and healthcare financing. We've also talked a little bit about how do we best build on and strengthen public-private partnership. But I think we also heard quite often that it's got to be a much broader coalition. And the fact that all of you are here, coming from various different sectors, groups, interest groups, it's really a clear sign that there is an appreciation of the fact that we all need to work together on this. So I think that's already a really good thing. Sue really pointed out some of the quite encouraging research advances that are being made, and that's something we can be proud of. But everybody has also raised the issue of financing, the issue of funding. How do we deal with this? How do we take advantage of what the government is thinking about in terms of the health white paper, which was approved last year. We're going to be moving to the implementation of the health white paper. The health white paper clearly identifies primary care, health promotion, health financing, governance as critical areas, and how those things will fit in contribute to the work that we need to be doing in terms of cancer control. So I think there's a lot of challenges, there are lots of good things that are happening, and the future doesn't necessarily need to be bleak. There's a lot of hope as well. Yeah. So I want to thank my friends and panelists, Noraryana, Soo, and Sound, and all of you for being here. I hope it was a helpful session, and really thank you very much. I learned a lot as well. Thanks.